hard for me sometimes to track them down because I wonder if they think it's more work than it really is.
Yeah, right.
Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to fill out the attendance record, and please also remember to fill out the program evaluation. And if you could give us ideas that you might have in regards to future topics and future speakers, we would appreciate those. It's my pleasure today to introduce Dr. Michael Kitchell, who's our speaker. Dr. Kitchell is a neurologist and the medical director of the rehab unit here at Mary Greeley Medical Center, but more relevant to today's topic is the fact that he's a past president of the Iowa Medical Society. He remains active nationally with the AMA and the Physician Consortium for Performance Improvement, and he actually has been invited to provide expert testimony on Capitol Hill regarding healthcare reimbursement issues, and we're fortunate enough to have him here today to discuss healthcare reform and the ACA law. And join me in welcoming Dr. Michael Kitchell.
So I hope you can hear me well enough. The topic seems to kind of come in and out of consciousness, but the politicians, I'm sure it's never too far away from their consciousness. There was a survey a couple of days ago that indicated that 81% of physicians didn't know enough about the ACA law to be confident enough to talk to their patients about it. So it's very complex. I'm just going to try to hit the highlights again and kind of put it into perspective as to where we are with healthcare reform. A lot of these healthcare reform issues have actually been going on completely separate from the ACA law. So the big issues in healthcare have been developing over the past 10 years, and that is, number one is the cost. We've got just unsustainable increases in cost, and something's got to change because our country will go broke if we keep on increasing the amount of costs going into the system every year. And as you probably know, 50 million people in the United States are uninsured, and that, of course, is far greater than we can really afford, because those people, when they get sick, they come to the emergency department, they get admitted, and somebody else pays for their care, either the taxpayers or the insurance. Those of us who buy insurance are paying more for our insurance because of that. And so one of the other big issues is, how can we prevent some of these costs, and how can we prevent some of these illnesses that cost so much money? The other thing that is a big issue is entitlement reform. We do know that Social Security is increasing, Medicare is increasing, Medicaid is increasing, and so we've got to have some way of doing a better job rather than just spending more money on these entitlements. And of course, there's always a concern about expansion of government control and mandates. Mandates are actually just a tax, according to the Supreme Court. And of course, how do we finance coverage? Who's going to pay for these sick people? So I'm going to start off with a quiz, and you can see the questions there. If you're an independent, you support the ACA law, pick number 3. If you're a Republican and oppose the ACA law, which most Republicans do, pick number 6. So pick those, and we'll have them tallied up, and we'll get the results here real quick. As you know, the most Democrats support the ACA law, or at least they support it and want it changed a little bit, and almost all Republicans have opposed the ACA law from the very beginning. Independents, it's kind of a mixed bag. Right now in the country, there's a little more opposition to the ACA law than there is support. So we'll finish polling here pretty quick. We're just about full of the polling. Okay, so if we can bring on the results here, we'll talk about them here. Okay, so just kind of as expected, the Democrats who support the ACA are far greater than any Democrat who opposes the ACA law, and the Republicans who oppose the ACA law are far greater than the Republicans who support the ACA law. And then, as you can see, the independents, just a few more oppose the ACA law than those who support it. So again, very much on political, philosophical lines. As we've said, the cost of healthcare in this country is staggering. It's a 2.8 trillion, or that's 2.8 million. So take $1 million times 2.8 million, and that's $2.8 trillion. So it's $8,800 for every man, woman, and child in this country. And the sickest people are the ones who cost the most money. The sickest persons in this country are costing about $80,000 or more per person. Those 5%, boy, if we could just cut those folks out, we'd probably save about half of the cost in this country. Half of the healthcare costs in this country are spent on 45% of the 45% of the costs in this country are spent on 5% of the population. So what can we do to take care of those sickest 5% to avoid that huge cost of health care? Now, this is not Mary Greeley figures, this is national figures, but 1 out of 200, 0.5% of the people who are hospitalized, it costs $560,000 for the hospital stay. But 5% of the people in this country who are admitted to the hospital, 5%, the average cost of their stay is almost $200,000. Now, we know that some people get admitted to the intensive care unit. They're there for a long time. They bounce in and out of the intensive care unit. They don't go home for a couple months. That's the type of person I'm talking about. Those 5% of the sickest patients in the hospital, not Mary Greeley's numbers, but national numbers, are costing $191,000 per stay. How many people could come up with $191,000 out of their pockets? Well, very few. So this is the problem. Some of those uninsured patients are costing $560,000. Some of them are costing $191,000 for the average of those 5% of the hospital stays. So next quiz. How are we going to control costs in this country? What's your best estimate? You can put number 5 other as, if you want a combination of these methods. The European method is obviously the government controls costs, the government rations care, it decides how much it pays for procedures, it decides how much people pay for out-of-pocket costs, and of course the doctors get paid fee for service. Low fee for service, but they get paid. So do you prefer the government does that? The insurance companies do that? Just have the patients entirely responsible for their costs? Do you recommend the HMO or maybe the ACO method of providers are paid a certain amount of money, let's just say $4,000 per patient, and use the money wisely? And then they partner with patients to help them make the right decisions. Or number 5, some sort of combination. Or if you have some other brilliant method, let's hear it. But anyway, so take your choice. Do you like number 1, which is the European, most countries' solution? Number 2, the United States usually has an private insurance-dominated healthcare system. Do you just want the patients to pay for everything, or do you want number 4, which is kind of the HMO, ACO type of method? It's not quite that simple, but anyway, just let me know what you think is best. And of course, if you think it should be a combination, or if you think it should be some other brilliant idea, put that down as your choice. Okay, so we're almost finished polling here. That's really the concern in this country, is how do we best control cost? And this is where the politicians are really coming up with some of these premium support programs, the Republicans really push this premium support. They're giving you a voucher to go buy private insurance, and you go buy your private insurance, and that's all you get. You've got to pay the rest of it out of your pocket. So that would be number two. So it's, again, not the financing, it's the cost control. How do we control costs? Okay, so I think we should be ready to tally it up here. Okay, well, most people are picking other. That's not a surprise. I'm a little bit surprised, actually, just how much we've got for the capitation. That's the ACO or the HMO way, where the physicians and the providers partner with patients to make a better decision on should you spend that much money. And then, of course, there are folks that want the socialized healthcare system. National healthcare coverage. The government is the one that makes that decision. There are a number of physicians I've talked to who say they don't want to have to make those decisions about whether that test or that treatment is cost effective, because every patient is individual, and they just want the government to say, yes, you can have that, or no, you can't have that. So again, I'm not too surprised that other is the desired choice. Okay, private insurance has increased over 100% for their premiums in the past 9 years. And right now, the average cost for a family to buy private health insurance is $16,000. If you work at McFarland Clinic or at the hospital, the total cost of that premium is somewhere around $13,000 to $14,000. Now, you and I are not all paying for that, but McFarland Clinic or Mary Greeley is paying for about 3/4 of that. And fewer employers around the country are offering health insurance. It's down to 57%. Now, luckily, that's still the bigger employers are buying health insurance, but that means 43% of employers in this country do not buy health insurance for their employees. Now, the problem, of course, is the ACA law may cause some of those employers to drop some of their employees or reduce them to less than 30 hours, because if you're less than 30 hours, you're part-time, and these businesses don't have to buy insurance for their part-time employees. That's been a long-term strategy by some companies. For example, Wellmark, they have a number of employees that are part-time, so they don't get insurance. That's been a long-term strategy. That's not just an ACA strategy. Now, some of you may recall President Obama, despite the law saying that there was an employer mandate in 2014 that the employers with over 50 employees had to buy insurance for their employees. President Obama decided on his own that these businesses didn't have to do that until 2015. And he did that knowing that some businesses would get rid of some employees and make them part-time. So the problem with the uninsured in this country has always been that if you do have a sickness, if you're in that 5% or that 10% of the sickest patients, the insurance companies are going to make you pay more. Now, we at McFarland Clinic and at Mary Greeley and most businesses, you don't pay more if you're sicker. You don't pay more if you're older. If you're 64, you're paying the same premium as a 21-year-old at McFarland Clinic or Mary Greeley. If you've had a chronic illness and you're really sick, your premiums are the same. You might have a little more out-of-pocket costs, but your premiums are the same. So that sort of socialized insurance is part of the employer-based insurance program. And as you know, with Medicare, you don't pay more in a premium. And with Medicaid, obviously, you don't pay any premiums. So for about 90-some% of the country, if you're older or sicker, you don't pay higher premiums. But if you are an individual, like a farmer or a small business person, if you have to buy insurance on your own as an individual, and that's about 6% of the country, you're in tough shape if you're sick. And of course, if you're older, you have to pay more too. So the insurers obviously increased the premiums to reflect the fact that each year these people got sicker, each year these people got older. And Wellmark last year increased their premiums 12 to 13%. And of course, they got a bad press because of that. This year, of course, they had no premium increase because now they're competing against the ACA website and those insurance companies that are selling Obamacare insurance. So again, employers have never made sick people pay more. They don't make older employees pay more. So again, that's kind of a socialized healthcare system. So as I said, only 6% of Americans actually buy their own insurance. And if you're young and healthy, it's not too expensive, at least before 2014. If you had a pre-existing condition, you were out of luck. You had some tough situations. So, as everybody knows, the Affordable Care Act was about 2,000 pages long, and most politicians didn't read it all. You know that there was a totally botched rollout of the federal website where people were supposed to sign up, and if you're like me and you get frustrated by computers, people got furious because they just couldn't get their insurance through the Federal Exchange website for Obamacare. And so that has kept a lot of people from signing up. Right now, about 9 million people have signed up either for Medicaid expansion or for the private insurance on the Obamacare website. And so that's 9 million out of 50 million that we need to sign up. The prediction as of today or yesterday was that perhaps by the end of the year, about 14 or 15 million out of those 50 million uninsured will sign up either for Medicaid or for the private insurance. Obamacare is private insurance, remember. Obamacare is expanded Medicaid and private insurance. Now, the Supreme Court, as you know, last June said that this mandate that people had to buy insurance was simply a tax, and so it was constitutional. And what they did do, though, was throw a little wrench into the Medicaid expansion, where the Supreme Court said that the states did not have to do Medicaid expansion. And as you know, Medicaid expansion was going to be paid for by the federal government for 3 years. So all these states that say, I want some flood dollars or I want some tornado dollars from the federal government were saying, no, I don't want any healthcare dollars. Okay, and that was like, okay, you want them to pay for tornadoes and floods, but not for heart attacks. Okay, that makes a lot of sense to me. But anyway, Iowa finally did accept Medicaid expansion, and actually it worked out really pretty well for, I think, everybody. It's about $800 million a year, helps the economy, and it potentially added about 150,000 more insured patients by expanding Medicaid. Now, the Republicans, as you know, have always had their own ideas about how to do more medical coverage for people. They want private insurance to be sold across state lines. They want defensive medicine to be reduced. They want more cost sharing, more copays, more deductibles. And as I said, that premium support is basically you're giving the patient the choice of which insurance to buy, how much copays to have, which panel of doctors to choose, which panel of hospitals to choose. And so there's more choice. And then the Republicans actually wanted to cut Medicaid by 30% using block grants. They would just simply say, okay, Iowa, you get $1 billion to cover your Medicaid patients. Use it wisely. So that was how they wanted to squeeze down the healthcare dollars used in Medicaid. So Medicare Advantage, I think you know, is a private insurance coverage for Medicare folks, and about 1/4 of the people who have Medicare actually have it administered by a Medicare Advantage plan. I'm not talking Medigap. Medigap is just paying for the copays. Medicare Advantage is the full spectrum of coverage for about 25% of the Medicare population. Now, getting back to the Medicaid expansion, only half the states are now doing Medicaid expansion to cover the uninsured with Medicaid. And as you know, Governor Branstad at the last moment compromised. And so what he did was he finagled it so that the private insurance would cover a portion of those potential Medicaid patients. So we have a similar Medicare Advantage situation. We've got Medicaid now being covered by these private insurance folks that are on the Obamacare website. And so they're using that federal money, the Medicaid expansion dollars, to actually buy private insurance for these folks that are between 100% and 138% of the federal poverty level. So the higher income poverty folks are getting private insurance, not Medicaid state-run insurance. And the other folks that are below 100% of the poverty level will be getting the Medicaid state-run insurance. So in 2015, Governor Branstad, if you've seen his proposal, Governor Branstad is planning on having statewide Medicaid ACOs. He wants every large group like McFarland Clinic, like Unity Point, like Mercy, like University of Iowa, he wants every one of those systems to have a Medicaid ACO in 2015. So as I was saying, I was going to use those Medicaid dollars, $800 million. Some of that $800 million will pay for those under the 100% of the poverty level, but those in the 100 to 138% poverty level actually are going to be able to buy private insurance with those dollars. And so the ACA law in a state like Texas would have no way of covering any of those Medicaid patients. Some of those Medicaid patients could buy their own insurance between the 100% and 138% of the federal poverty level and get some subsidies to buy that. But if you're not in Iowa, if you're in those 25 states, you're out of luck. You don't have any way of buying or getting insurance unless you want to buy it in that 100 to 138% category. Like I say, in Texas, you're buying private insurance, but you're not going to get the state-run Medicaid in those 25 states. So the question, of course, is federal expansion money to buy private insurance, is that really a good cost-effective decision? Is private insurance cheaper than the state-run Medicaid? And we'll talk about that a little later. So the health insurance exchange is this website. It is an exchange. You can phone these insurance companies and get your Obamacare insurance through these private insurers too. But the health insurance exchange, like I say, the website was totally inoperable for about a month, and it's still kind of limping along, but I guess more people have been able to sign up now. Like I say, 9 million have signed up either for Medicaid or the Obamacare private insurance. And on that Obamacare health insurance exchange, the subsidies and tax credits, which are paid for by Obamacare, will help to lower the price for people in those lower levels of income. That's between 100% and 400% of the federal poverty level. For a family of four, that goes up to about $80-some thousand. So people who have an income level of $40,000 or a family, they actually have pretty good subsidies to buy down the cost of that private insurance. In Iowa, though, there are only two statewide private insurance companies that are offering these plans. That's Coventry and CoOportunity, which is a not-for-profit company. CoOportunity apparently has signed up about 60,000 Iowans, so they feel like they've been pretty successful so far in the marketplace. Like I say, about 150,000 Iowans could be covered, so signing up 60,000 is a pretty good deal. Wellmark and United won't participate in the Obamacare exchange in 2014. They might in 2015. Premiums, as I said, they're going to be to distribute this cost of insurance. What the insurance companies have to do is they have to get money from younger and healthier patients to pay for the older and the sicker patients. And so these products are priced so that the highest 64-year-old cost versus the lowest 27-year-old cost is only a ratio of 1 to 3. So if you look at the Coventry and the CoOportunity costs of these premiums, you'll see that the maximum differential is 1 to 3. In the reality of the world, it was more than a 1 to 6 difference. In other words, if 64-year-olds insurance premium was 6 times the 27-year-olds cost of premium in the real world before Obamacare. So again, this really compressed it, makes things more expensive for younger people, makes things more expensive, obviously, for healthy people who could have bought an individual policy before. If they were healthy, they could buy it for a cheaper price. And that's where you heard at when the insurance exchange came out, all these young, healthy people were seeing these big premium spikes because Obamacare was more expensive for these younger, healthier people. But it's much cheaper for the older, sicker people. And of course, if you have low income, Obamacare can pay almost the entire premium for some of the lower income folks. So again, at the free medical clinic, we push people to sign up for Obamacare. It's crazy not to sign up for it. So how many young and healthy people will not sign up for Obamacare? Quite a few. There are still a lot of people who are not going to sign up, and there are some low-income people who just don't trust Obamacare, and they're not signing up either. So again, that's why I said perhaps by the end of the year there will be 14 to 15 million new insured people through Medicaid or through the private insurance. But again, potentially, if you count the purchasing people through the health insurance exchange that are looking for individual premiums, and then you take the Medicaid expansion, 250,000 Iowans could be buying from that insurance exchange. So CoOportunity has got a nice little niche and market share that they're going to be around for a while. So as again, I was saying, the employer mandate, businesses over 50 employees are not going to have to purchase insurance. There's a penalty of $2,000 to $3,000 for each employee who wasn't going to be covered. That is a pretty stiff penalty. But look, if the employer is paying $10,000 or $12,000 for insurance per year, what's a $2,000 to $3,000 penalty? A lot of businesses were really seriously considering just paying the penalty and let the government take care of those folks. And then you might have read something in the newspaper too about some people are deciding, I'm just going to work part-time because if I get paid more money, that means I get less subsidy for my health insurance premiums. And so I'm just going to work part-time and let the government pay for my health insurance premium. So kind of like what happens in Europe, the government pays more. So again, what is happening so far this year, though, is a lot of sicker patients are signing up, and then you say, oh, those insurance companies are in trouble because all the sick people are signing up, and then the healthy people aren't signing up. Well, the insurance companies did a deal with the politicians before the ACA Law actually came into place. They can show that if they just take care of sick people, they get some extra money. So don't feel too sorry for the insurance companies that might take a bath because only sick people sign up for their health insurance. The insurance companies got their concession from the government. Okay, the summary of the ACA Law. Tax credits are being given to businesses, particularly small businesses, if they want to sign up their employees for the ACA Law. And of course, the penalty was postponed from 2014 to 2015 for the bigger businesses. And then the requirement has been to have an easy-to-read health insurance summary. And there are both some people who can facilitate people signing up. They have to have some official designation, though, as a navigator to help people sign up. And then, of course, the typical insurance brokers in Iowa can help people sign up for this, too. And then again, the big issue for Obamacare is that subsidies will help people actually have an affordable cost for their insurance on Obamacare. The rub, though, is if you have some of the lower cost premiums, they're called the bronze and the silver level, there's also catastrophic level, the cheaper premiums, there's more out-of-pocket costs. So some of these out-of-pocket costs in the silver level, which is the medium-priced one, some of these out-of-pocket costs for families are $6,000 a year. How many people have $6,000 a year? So doctors are concerned that if a lot of people buy bronze, catastrophic, and silver plans, the out-of-pocket costs, like where's your $6,000 that you're going to pay the doctor or the hospital? There's going to be a lot more bad debt with Obamacare too. So we haven't seen that yet, but it's probably going to come because some people are just not going to pay $6,000 out-of-pocket costs. As you know, there's free preventive care if you sign up for any insurance now, whether it's McFarland Clinic or Mary Greeley. You get a free colon exam if it's necessary. You need a mammogram. It's free. Vaccinations are free. So preventive care is mandated to be given by the insurance company for free. And then, of course, children aged 26, they got advantage of this early on with the ACA Law. So what are the criticisms? Obviously, you've heard a lot of them. Too much government involvement in health care. This law actually took $716 billion out of Medicare payments for the future hospital costs. The American Hospital Association said, okay, we agree to do this as long as these uninsured patients don't come and have no insurance, because these hospitals were taking big losses. 27% of patients in Texas are uninsured. So if you're a hospital in Texas, 1/4 of your patients aren't going to pay a red cent. So the hospital said, oh yeah, okay, if we don't have to pay for that, 27% of the population, we'll take a Medicare cut. That was the deal. But then Texas decided that, okay, we're not going to take Medicaid expansion. Well, those people are still uninsured. And Texas is refusing billions of dollars of federal money to cover these people. So the hospitals in Texas, what do you think they're thinking? I know in Ohio, the Hospital Association spent millions of dollars trying to get the governor, and they got the Republican governor of Ohio to agree, we got to have Medicaid expansion here, because the hospitals are going to take a huge cut, a huge loss, because all these people are still uninsured. Texas, it's not quite as easy for the hospitals to get the politicians to listen, but again, that's why the $716 billion cut was agreed to by the American Hospital Association, because the hospitals weren't going to take as much loss on those uninsured patients. California, has about 23% uninsured, but California was very eager to take those federal dollars. And New York State is taking the federal dollars. So it's mostly the southern states that have decided not to. So what do we expect here for the Obamacare era? Some employers will reduce full-time workers to avoid buying their insurance. Some small companies will drop insurance, pay the penalty. Young people will avoid buying the policies, and out-of-pocket costs will lead to more bad debt for physicians and hospitals. So again, why I told you that question, when the federal government is buying private insurance for Medicaid patients, is it cheaper? No, actually it's not. Medicaid is quite a bit cheaper than private insurance. The average Medicaid costs are about $3,500 to $4,000 per patient per year. If they're insured in an insurance product, it's about $6,000 per year. So it's actually more expensive for private insurers. Why is that? Are private insurers more inefficient? Well, each private insurance company is mandated by the ACA law that only 15% of the premium actually goes to the insurance company. 85% has to go to the providers. Okay, so their overhead can't be more than 15%. And so it's not just in overhead. Medicaid pays providers a whole lot less. Medicaid pays neurologist about almost half of what a private insurance company pays for an E&M code. Now, the ACA law has required Medicaid payments for primary care doctors, not specialists, primary care doctors, to go up to equal Medicare payments. So everybody who's a primary care provider got a nice raise for both Medicare and Medicaid patients for the Obamacare results. So again, who is more efficient? Is the government more efficient or are private insurers more efficient? Well, that is something that still remains to be seen. But again, it is a little cheaper to have government-run healthcare than private insurance. So what's happening, though, both in private insurance and in the government? There's more focus on value. That means higher quality, lower cost. No matter whether you're buying a car, a television, you want more value and you want higher quality, you want better products at a lower cost. So healthcare is simply doing the same thing, and this is called value-based purchasing. This started long before Obamacare came into being. And as you know from my previous talks, Iowa providers have always been very high. The Commonwealth Fund ratings still show Iowa's #1 for kids, #2 for adults. One thing I did want to talk to people about, though, is Wellmark is doing quality ratings. It's called the Value Index Score. McFarland Clinic is #1 in the state in quality for the 9 largest systems. That includes University of Iowa, Unity Point, Mercy in Des Moines, the statewide systems. The Wellmark quality measurement shows that we are #1 in quality. If you look at our Medicare ratings, we're in the upper 7.2% of the higher quality, lower cost providers. So in other words, out of the 1,000 large medical groups in the country, McFarland Clinic is in the upper 72 groups in the country. Out of 1,000 large groups, we're in that upper 72, that's 7.2% in the country. And if you didn't see the report, Mary Greeley recently, out of about 3,000 hospitals in the country, for this value-based purchasing, which is Medicare quality indicators and patient satisfaction indicators, Mary Greeley was 19th in the country. And so we need to give everybody credit here for that. But so if people think, wow, how good is our quality here? Well, it's pretty good. And so that's going to help us in the future to be successful if we can keep this high quality, low cost type of system going. Because the current system rewards value. If we do more tests, more procedures, more everything, we get paid more. But in the future, value is the word. And so what it's going to do is it's going to give physicians the responsibility of keeping people healthy, keeping them out of the hospital, keeping them so they don't have such high costs for their drugs, so they don't have such high costs for their durable medical equipment. The total cost of care is what physicians are being asked to take responsibility for. Physicians are going to be held accountable for the total cost of care. So does that mean when a patient gets sick in the nursing home, we'll say we'll see them the next day? No, that means the physicians are going to have to take care of that problem that day so the patient doesn't get worse and bounce back into the hospital. One of the biggest reasons Mary Greeley was so highly rated in value-based purchasing was our readmission rate. Our readmission rate here is nearly the lowest in the country. One of the biggest reasons McFarland Clinic got to be so high in the quality resource use report, that's the quality ratings, is that our diabetic admission rate, readmission and admission rate, is 1/2 of the national average. We were about 70th, we had about 70% as frequent admissions for COPD and asthma as well. So again, we're doing a higher quality job here. People are getting hospitalized far less frequently. Do you think those diabetics who don't have a heart attack, who don't have a stroke, who don't have kidney failure, who don't have an amputation, appreciate that? I think they do. And that's what the insurance companies and the government are realizing, that better care leads to lower costs. And in fact, the U.S. House and the Senate, those of you who've heard me talk earlier too about the sustainable growth rate, which is a built-in payment cut every year for physicians, the remedy for that actually is to promote pay for value. They are going to increase payment for physicians that are accountable and physicians who have higher quality on the quality measurements. So as I was saying, this accountable care is really giving physicians the responsibility to keep the costs down, keep people healthy, keep them out of the hospital, keep their cost of drugs and durable medical equipment down. And so these measures of quality and cost are really with us to stay. In total, there are 460 accountable care organizations in this country. Half of those are Medicare, half of those are like Wellmark, private insurance accountable care contracts. And there are 9 systems in Iowa, just like I said, the University of Iowa, Unity Point, Mercy, Des Moines, Mercy Cedar Rapids, McFarland Clinic. We're all ACOs now. And so again, for physicians, what our challenge is to reduce hospitalizations, ED visits, durable medical equipment, drug spending, improve the patient's function and health by prevention. This concept of narrow networks is what was publicized too with Obamacare. These insurance companies, for example, in Los Angeles, the insurance companies in Los Angeles have decided to exclude 7 out of 9 of the hospital systems in the Los Angeles area. They're not in their network. So if you want to go out of network, you got to pay more. But 2 hospitals in Los Angeles are in the narrow network, and people who go see those providers have lower copays, lower out-of-pocket costs, and they can expect higher quality care than those 7 other hospitals in the Los Angeles area. Could that happen in Iowa? It actually already is. People who have chosen the Coventry Unity Point product can actually get a discount if they only go to a Unity Point provider. So in the future, if Unity Point shows that their quality and their cost are not as good as McFarland Clinic, would we have a lower cost for the insurance product? Most likely. So that's what narrow networks are all about, is steering people toward the higher quality, better results, and lower cost. Do some of those physicians who are part of the narrow network have to take a discount on their fees? You betcha. So narrow networks, though, don't have really a whole lot to do with Obamacare. They were there long before Obamacare. So again, the payment methods are changing. The way that ACOs get paid is with shared savings. And other insurers are using pay for performance. In other words, if your quality is high, if your readmission rate is low, they'll pay you more. Medicare and Medicaid, as I said, are rapidly going toward ACO options. Half of the ACOs in Medicare last year actually showed some shared savings. About 25% of them actually made quite a bit of money off the shared savings in Medicare. So if you're looking at it the other way, half of them didn't. But in any case, if you pay attention, if you do a good job, you can reduce costs and you can improve quality. So as most of you know from my previous talks, about 30% of healthcare in total in the country is felt to be spent on unnecessary and wasteful care. And that is in part due to fragmentation of care. Go to one doctor for one thing, go to a different doctor for another thing. They don't collaborate, they don't communicate, they don't coordinate their care. And obviously, you know how we do it here, we coordinate care. And so these gaps where patients don't receive the right care, we still have some gaps. I mean, some people get discharged and unfortunately they don't make it back to their provider's office, either their primary care physician or their specialist office, and then they get sick again and then the costs mount up. So again, what the new healthcare payment is going to do is put responsibility for outcomes and for keeping people healthy right in the physician's laps. Now, most people say, okay, what's the difference between an ACO and an HMO? Well, ACO, the patient has a complete choice of providers. It's only the insurance company that's giving them the narrow network, okay? So if somebody is in Wellmark and comes to McFarland Clinic, if they decide they want to go to Mayo Clinic for whatever, they can. It's only Wellmark that says you got to pay more if you go up to Mayo Clinic, you got to pay more if you go to Washington University in St. Louis. That's out of network. So the ACO, the providers, are not the ones fencing people in. It's the insurance products or the narrow networks that do that. So ACOs are not HMOs. HMOs, of course, fence people in. But ACOs, we hope that the patients will trust us. We hope that the patients are happy with their care here. We hope that they don't feel like they need to go someplace else. So, as you know, HMOs are often run by insurers whose biggest strategy to reduce costs was to limit care. And so ACOs are seen more as patient-centered, and their goal is to engage patients. As you know, preparing for the future, better care, use the tools of the electronic health records better, engage patients, get more prevention, and be more efficient. So again, as we talked about at the beginning, there are unsustainable increases in healthcare costs. How do we control costs? ACOs seem to be a popular method right now. Seems as though the early results are good. And there's no question in the future we've got to be higher value than our competitors because there will be transparency in quality, transparency in cost, and patients will choose. And then it's very clear higher quality is a result of organized, integrated teams and systems. And when I talk about teams and systems, I'm talking about the nurses, the therapists, the receptionists. It's a team type of approach. And then, as I said, we need to have patients more engaged. If you have a diabetic who's not engaged, who's not complying, who's not adhering to your advice, they're not going to do as well. And that's what we're trying to do. We're trying to get patients engaged to help take care of themselves. We probably are lucky here in central Iowa that, we have a higher percentage of engaged patients than elsewhere. But hey, that's why I came here. So any questions? I'll try to answer some if they're brief.
Mike, you hear the 3%, 4% cost of administering Medicare, Medicaid versus 20+% in the private sector. Do you buy those numbers?
Well, I think the private sector, like I say, they're limited to 15%, so it's less than that. You do have to admit, though, that the government does take some effort, it's called the Internal Revenue Service, to collect those dollars from taxpayers. And so exactly how much the government is spending, it's more than 3 to 4%. And there might be some really efficient insurance companies whose administrative costs are 9%, 8%. So I think that there is a difference, but it's probably not huge. Because part of what the insurance companies have to do is they got to pay the broker, they got to pay the folks to get people enrolled. So it's not just advertising and overhead that is spent on fluff. But again, some of the things that Wellmark spent their money on, for example, was pre-authorization. The nurses in here know what I'm talking about. How much time did you spend on the phone or on the computer or waiting for Wellmark or United Healthcare or some other insurance company to okay that CAT scan or okay that procedure? So some of those costs were meant to reduce costs, but that's still overhead. And of course, Medicare doesn't have any of those, well, except for oncology. Medicare doesn't have any of that pre-authorization stuff. And so again, you kind of have to look at the insurance companies were using some of their dollars to reduce costs. So there's a difference, but if you just look at Medicaid, they pay providers less too, so it's cheaper than the insurance companies. Okay, well, I appreciate everybody's interest and hope you learned something today.